So one of the unique things about experience, right, is you get to walk into whatever your new environment is and hopefully translate some of those things. So I was really excited to be part of the keynote because I was a child that was diagnosed with asthma, lived asthma, became a pharmacist, and that's like I was so determined that somebody wouldn't have my same medical experience translating from being a young child, a teen, young adult, a middle-aged adult, so that, kind of understanding that. And that was one of the things that made it very easy to connect with patients, is because you can have a conversation differently when you had the same symptoms or when you thought things a different way. The other component was just really the power of health literacy. And then when you add literacy issues on top of health literacy issues, it makes for a very unique opportunity for patients. And it's so important, and it often gets overlooked. So our learning objectives, you guys can read those, but looking really at the challenges of self-management, teaching it, making sure that it's something that's incorporated and not just something that you're expecting the patient to be doing in between. And a lot of our patients, we see them sort of surrender control to the provider. And we do have a lot of initiatives, and I think a lot of us are aware of that, where we're trying to get more ownership back into the patient for the care that they need to manage their disease state. But there are still some patients who they've just surrendered it. They really aren't trying to be their own champion. And that's where really having the conversation for self-management is so critical. So just to kind of start off with kind of where this is going is, what do you recognize or identify as failures of the healthcare system that lead to unsuccessful management of as a patient, right? What do you recognize? What are those stopgaps, either that you have experienced, someone in your family has experienced, or your patients have experienced? And thinking about those, that's where there's an opportunity. There's an opportunity to change. There's an opportunity to create a new policy. There's an opportunity to create a new pathway to either reduce, prevent, or correct, so that no longer becomes an issue. The other is thinking about where has health literacy created barriers that are perceived or actual, because that's one of the issues with health literacy, is not that there's actually a barrier, but that there's thinking that the barrier exists. And that's really the importance of making sure that as providers, we know what resources are in our community, because our patients can very often and very frequently think that there's no help available to them. And we have to make sure that we are helping them overcome the perceived as well as actual barriers. And that comes from being aware and having those conversations and partnerships with every level of care in the community. So if we just kind of start looking at the challenges with asthma self-management across the different ages, right? So our whole theme is to kind of really talk about how this affects different populations and different. So the weight of the worst, right? We know in care, our reimbursement for providers comes from, quite often, the weight of the worst. So the patients who are often the most non-compliant, patients that are not optimized on therapy, aren't refilling like they're supposed to, they're accessing emergency services instead of primary care, they're behind on immunizations, they're behind on these different services. They negatively affect the reimbursement rate for providers. So if you think about the weight of the worst, if you can just lift that weight a little bit, then it shifts the reimbursement scale. And that reimbursement scale opens up new funding opportunities for either additional people in your clinic or for a different rate of reimbursement as the provider providing that care. So there's really something to think about when you talk about who are the patients that you're struggling with the most, and what can we do to step into figuring out why. How creative can you get as to why? Is it the perfect treatment? Is it the best care available in that community or wherever the patient is receiving services? What is the piece that's missing that's creating a break in what could potentially be a very successful intervention with a completely different quality of life. So we know disproportionately that we have effects with severe asthma, right? So they're not our largest population, but they are our greatest spend. So they cost the most. And so you don't want to, from a classroom, you don't want to invest all of your time in the students that aren't doing well, because then the students that are doing well miss out on the type of care that they need, but you can't leave them behind. So our patients with severe asthma, getting that under control often takes an additional round of support. And that comes from those conversations. It comes from knowing the community, engaging your community health workers, engaging the level of care outside of clinical, outside of primary care, outside of specialty is really kind of this gap that we have to fill. And we've got services available. We're just not as connected as we need to be. We notice too that with changes in diagnostic criteria, how we are addressing patients, how we're identifying who is severe, whether they're controlled, getting that conversation so that all the providers are at the same level. Because if you start off with a patient that's not diagnosed correctly, they're never going to be treated correctly. And it could delay the treatment that they need, and it could actually lead to greater morbidity and mortality for that patient because they have not been optimized in care. So ensuring that the quality of care is where it needs to be comes from making sure that that education and that conversation are happening. And whether it's driven by the primary care, whether it's driven by a specialty, whether it's driven from another clinician, another person from the community, this is really where we have to move that conversation. And we've really kind of spent a little bit of time talking about that with our provider work group. But underutilizing the appropriate staging is an essential component of changing the effects of asthma on populations. And whether it's peds, whether it's the adolescent group, whether it's adults, or whether it's seniors, there's really a lack of awareness consistently on where we want to optimize care and who's actually receiving that. And we aren't talking about the physicians and the specialists that are here, right? We're talking about the ones who aren't that connected or aren't engaged. And that's where the outreach, that's where that can happen. So we don't have to rely on the specialists to bring the information to the team. If someone has information that they know, bring that to your team leads, bring that into your primary care, bring that into your specialist to say, here's something that we might be able to implement. Here's something that I learned. And that's really the beauty of that conversation. The amount of education and resources that is available to clinicians is astonishing. And it is so different than 20 years ago, than 30 years ago, than 40 years ago. And keeping up with all that information is a challenge, but this is the opportunity for that exchange to have and tap into some of those champions for different professions, but also champions from different approaches to the management of our patients with asthma. We have the unique characteristics of the patients and their caregivers, right? A lot of what Dr. Luca was talking about with the social determinants of health. There are unique components that chances are someone on your team can relate to. Something that gives you the opportunity to connect with that patient in a way that they now have that buy-in. And those nuances between different patients, instead of that being something that creates barrier, is actually something that can be a partnership point. And that's something that we start seeing that more and more. The conversations that we are hearing as members of the Florida Asthma Coalition are reflecting that. So that's a movement that we want to see continue, and with the weight of everyone having an opportunity to contribute to that. So the Institute of Medicine defines self-management as the tasks that individuals have to undertake in order to live with one or more chronic health conditions. Right? So one or more. How many times do we have a patient with asthma who never has any other issue going on? Not allergies, not eczema, not any other component, food allergies or environmental allergies, right? So these patients are not coming to the table with a siloed disease. They are coming with a platform that has several different components. Maybe it changes with the environment, maybe it changes seasonally, Maybe it changes as they are navigating their own environments between school, home, and other environments that person, patient, might experience. So what we want with self-management, the key for successful self-management is to build confidence, right? When we build confidence, it's repeated exposure, it's teach one, right? Reach one and teach one. So modeling it and having it shown back with a teach back opportunity. And that has to be repeated to where there's competence, right? So we have to get competence before we even get to competence, before we get to mastery. So we can't just have it be a one-time interaction. It can't be a one-time exposure. So at every point of care for the patient, there has to be a touch base. There needs to be an assessment. There needs to be a review. There needs to be a show me how you're using your inhaler. Let me know what has changed between, the spring and the summer. You'll have a lot of patients then you'll be able to identify at that point where misuse is, right? And they honestly believe they're using it right. The number of times patients have said, do you know how long I've been on it using an inhaler? And I'm like, probably as long as me, but I still want to see you use that. And almost all of the time, they're not using it correctly. And you can have the right drug at the right dose for the right patient being used at the right time, but it's used the wrong way, which means it's not going to work. It's not going to be where it needs to be to have the effect that it needs to have. And so really having the relationship and the provider relationship is something that's very sacred. You never want to be in a position where you are sabotaging or putting something in that relationship at risk for the patient, but it's certainly an opportunity to reach out to identify potential gaps that you're noticing that maybe they don't see at the primary care office, or maybe it's something that they've mentioned and you want to make sure that the primary care provider is also aware of those issues. Making sure that we have the education and the training that goes across each member of the care team. Because if the MA doesn't understand what they're doing and why, their technique of screening, their technique of doing a point of care assessment isn't going to yield the right results for the provider that's going to come in and see them, and the providers depending on that. So it's really a multifactorial, multi-level component that if we create the relationship and we give that patient the opportunity to build confidence, that we're going to see the greatest outcomes from self-management. One of the challenges for me was that my parents both were master's level educated people. So they go into the doctor's office, they realize that there is, an educated person. And so they have a conversation as if the person, my parents, understood what they were saying. And they didn't, because our education and our health literacy are not equivalent. So my parents understood that if I was having problems, then I needed to use my medication, but I really didn't need it if I wasn't having problems. And that is a very common misnomer that we see with our patients, but with our caregivers. So it's really important to educate caregivers, whether there's nuances from an ethnic perspective. Dr. Perpich and I have kind of run into those issues and barriers as well, that there might be a patriarch, and what the patriarch says goes. But if the patriarch is wrong and the family knows, they're not going to correct them, and they're not going to change the way they're using the medication because that's not okay to do. So again, until we end up in those conversations, until we have the relationship to be able to find those things out, we continue to have a miss after miss after miss. When we think about guided self-management and skills training, these are certainly opportunities for us to engage with our patients. The issue is time, right? Having the time to do what we need, being able to obtain the reimbursement for those services, that affects every component of healthcare, every part of us. We have to be able to do those things. We have to invest in those times in order to actually reduce morbidity in children and adults. Without the ability for self-management, we see statistically an increase in morbidity for patients that have a diagnosis of asthma. So if we have a literacy issue, if we have a health literacy issue, and there's not a relationship with that patient, then our patients truly are at a greater risk. And there are too many points within the healthcare system for that to be a continued miss. When we have the shared decision-making, this is again, when patients have embraced that they're not the decision maker, it makes it challenging to get our patients to the level that we need and the goal that we have for them. But if they're part of the decision-making and we find out what their goal is, then there's a little bit more buy-in. And if we know what their goal is, when we achieve that goal, then we can move them to the goal that we have that's probably a little bit more robust. Because trying to take them from 0 to 100 is never going to sustain as a daily behavior for them, because we have to work to where they experience the success. We want them to be clinically at certain levels. We want their PFTs to be someplace. We want their number of their exacerbations, their symptoms, but they may just want to be able to do a specific thing. And having the relationship gives us the opportunity to draw that out. And by drawing that out, we can then identify, how are we going to get them to here? And then once we're here, what's the next goal? And then what's the next goal? And that also gives us the opportunity then to address and identify those perceived barriers and the actual barriers. And deciphering the two of those gives us an opportunity to change the course of the patient navigating through the health system. Inhaler technique is one of the biggest issues that we have for patients. And we just had this conversation walking out that when you go to a pharmacy or you interact with a pharmacy, they have to offer to counsel, right? So OBRA 90 says you have to offer to counsel a patient on their medication. No one has time. No one's going to take the time. The rule should be that any new medication requires a sit down, at least 15-minute, go over the medication, go over the side effects. How do you know if the medication is working? You want to know, how did your doctor tell you to take it? What did he tell you it was for? And what is the expectation? What is it going to happen with this medicine, and what's going to happen without? And just having those 3 points changes the conversation for the patient, and it starts to build that relationship. And it gives you an opportunity to assess, do they understand what they're taking, why they're taking it, and how, or how to use it. And the retraining that needs to happen repeatedly for patients that are using inhalers or devices is overwhelming. And when you have environments that are not conducive to that training, that's where we see learned behaviors or learned techniques that are not appropriate, that are not going to give success, that are not going to yield outcomes that reduce risk for patients or improve their outcomes. And so those things are really important. Moving from compliance to adherence is huge. It's a mindset, it's an expectation. It really reflects relationship and buy-in when you have a patient who's adhering because they understand what the benefit is, as well as the risks for not, but because they want something different. They want a different outcome. And that's where we really want to meet our patients. We want to meet them in that space. And literally the opportunity to get patients with peak flow meters that mirror, if they're done and performed correctly, can mirror what we see in pulmonary function testing. If we know the peak flow is not well, if you go in and you test them with spirometry, we see that their results with spirometry are also low. So we have those devices, those opportunities for points of care that give us that reflection or that representation of where things are at a clinical level. And teaching them, empowering them is a huge component of that. One of the things that was profound for me is when I was sitting in graduate school learning about the respiratory system, I was learning things about what my lungs did that I had never knew before. And I was like, how is it that I'm this 30 years old learning this when it would have changed things for me? I mean, I still had dreams to be a track star. That was never going to happen. But I like to pretend that my asthma uncontrolled was the reason why I couldn't run as fast as everybody else in college. I just was not fast. But I can't, I mean, I was kind of okay. I was okay. But I can't run for pleasure. I can't do certain things if at that point, because I had no idea the level of control and the lack of control and the level of inflammation that I had experienced. And I was a very good patient. I went to the doctor every year. I filled my prescriptions most of the time. I remembered to take them most of the time. And I thought that that was good. Then you learn that without at least 80 to 90% adherence, you're not going to get benefit from the medication, that all of these different experiences were not normal for a person with a diagnosis, and that things that you may have wanted to do and the course of things that you wanted to do over time have been greatly impacted by the damage of inflammation, longstanding and repeated exacerbations that could have been prevented. And so that's where driving passion for me with asthma management and self-management became such a huge part of what I do professionally. And that's just, it's something that you can't, learning about it after the fact is such a frustration. When, granted, we didn't have as much information when I was younger. We didn't have as the guidelines are certainly more on point right now than they were 30 or 40 years ago. But 50 years is a long time to have a disease and it not being controlled except for the past 20. And so you think about all of those things, and we have our patients that are still walking that story out. Those are the ones we really have the opportunity to impact and to impact differently. And knowing that things look differently as peds, they look differently as adolescents, and they look differently as adults is an important component of when we are in care of our patients, and why we have pediatricians, why we have our primary care, why we have our specialists, why we have our subspecialty groups, because at each component, there's a different piece that they bring to the table. So the key challenges for self-management, right? What are we up against? What are the barriers that our patients face in adopting the strategies for self-management, right? Their own knowledges of risk factors. When you sit with patients and you try to identify triggers, that's a huge component. There was a patient, I'm not sure if Dr. Perpich will remember, but the parent was concerned about high altitudes. And the child was going away to a camp and was going to be on the top bunk, right? The parent was serious. So those tiny little nuances, right? Just as a reflection that there are opportunities for health literacy education. And had the parent not shared their concern for their child on the top bunk, it wouldn't have been obvious to us that there was something. And like when that happened and we looked at each other and I was like, and then he got up and he left. And he's like, we're done here. You can continue education. And I was like, oh, okay, great. I don't even know where to go with this. This is the first time I've ever heard that. But it was, I was traumatized. But it really is. It's, you know, and we laugh about that, not to laugh at the patient's caregiver, but to laugh in those moments where you're like, it's incredible what they think. And without a relationship, you don't know those things. And I'm sure it's not obvious, but Dr. Perpich is a very engaging provider, right? And so for most of his patients, relationship is a huge component of that. That was obvious to me coming into that clinic setting. Relationship is a priority, and it's a priority for him, and it's a priority for the rest of his team, which is incredible. And that is a game changer for patient outcomes. That shared decision-making, right, where the patient actually weighs in, gives feedback, right, prompted with the right kind of questions, gives them an opportunity to help make decisions that are going to fit their lifestyle, because medications that don't fit the lifestyle aren't going to get used. Medications that have side effects that are not tolerable, they're not going to be used. And by understanding what the concerns are, by understanding what the challenges are, different decisions can be made that allows for a completely different outcome. And that's really what we want. We want to understand health beliefs. And I teach this, and I've taught this for years, that when we want to look at how do we change outcomes, what do we need to do to change? There's a flow of how this goes. You have a health belief, and what you believe ends up being what you do. So our health beliefs lead to health behaviors, and our health behaviors have a consequence, good or bad, which is our health outcome. So if you want to change a health outcome, you have to go back to change the health belief. If you don't, and you're only focused on the health behavior, that's not sustainable. And that's why when our patients come into clinics and they come into ambulatory management, or they have those 6 sessions with respiratory, they do great, and then they're done because the behavior didn't have anything to sustain it, because the belief didn't change. And that's where relationships are so essential, is changing the health belief, and then watching how the belief changes the behavior, and then monitoring whether or not that has led to an improvement in the health outcome. And that's really the essential component of self-management, is if you want them to manage it well, they have to understand it, they have to get coached on it, and then they have to integrate it, because that's when we have behavior change over time. Some of the barriers are assimilation of the guidelines. So certain providers are really good about bringing in the guidelines, but when the guidelines, and Dr. We've kind of talked about it now with all 3 of our specialty providers, is that if there is a discrepancy between the guidelines and the FDA approval, certain things aren't going to be covered, whether it's they're rejected by the insurer, or the patient uses the medication the way that is intended to be used, but then they can't get the refill because it's been used a different way than what it's currently approved. So sometimes the FDA approval is behind where the guidelines and the recommendations are. And when we have that discrepancy, it's important that when a patient receives that prescription, to reach out to the provider to say, this patient is going to run out of this medication after 20 days. That leaves 10 more days in the month before they're going to be able to get a refill. What do you want to do? Do you want to continue that, see how their benefit is, try, and then the third-party rejections and the dealing with the denials and having to go back and forth to get the approvals, that can be a challenge. And in the interim, your patient is then without treatment. So there are challenges that we have to overcome. Assimilating the guidelines doesn't always line up with where things are at. One of the biggest frustrations, and we talked about that, is wanting to support the care that was developed and intended to be implemented by the provider. And then there's hangups with getting the medication to the patient. Those are challenges that have to be communicated, and collectively coming together to utilize the Florida Asthma Coalition and other groups to have that as their benchmark for communicating changes in policy is a huge component. And a lot of that is driven by data. If we don't have data, we can't drive the information that makes a difference to the people that are making the decisions. And so that's a huge component. When we can get the guidelines implemented with all of our care providers, we know that they foster those changes. And by fostering those changes, we have the results on our patients. If we don't have change, if we're not getting our patients evidence-based treatment, interventions that optimize care, reduce risk factors, reduce morbidity and mortality, we do see a negative impact. And that's a challenge that we are continually identifying and looking for those opportunities for improved education. Making sure that we can overcome those barriers individually with our patients and understanding that helps us build into population health initiatives, community health driven initiatives. So understanding that certain unique characteristics within our care circle. So if you're a provider, you kind of have a range of how far your patients have traveled to see you, and everything within that geographic area is an opportunity to build a relationship to identify resources, support, education, outreach, community for the caregiver who might be challenged by the disease state, because it can be very isolating. It can be isolating for the parent. For the child, understanding that a child with a chronic disease also carries with them an identity of disease, right? And then from that, you also have siblings that can, siblings always say the most loving things, especially as children. They made us miss this again. You're always getting sick and we can't do this anymore. We can never go here because you always get sick and we have to go to the hospital. Those are things that children carry. It's not intended to be bullying, but it is an identity that children with chronic diseases embrace and they identify with, and that carries with them a level of guilt. And understanding how then anxiety and other issues, mental health issues or feelings that are very strong can even become re-triggers for the patients. And so really kind of looking, at those opportunities is really another component, and screening for those things. We want them to be autonomous. We want them to get to the level that they can, that's age appropriate, that is, they have the physical ability to be autonomous. We know that there are some times that children very young can be educated. Part of the Open Airways in Schools program is not just to target children with asthma, but to actually educate the children around them who don't have asthma so that they can see changes in their friend. Because it's very obvious to children. They know. And if a child is at a place where they can't speak, or if they have that where they know that there's something wrong, turning to another child that's a friend of theirs, and that child can then run to tell an adult or find an adult to let them know that there's a problem. Those are huge components. Those are those psychosocial drivers. Those are the opportunities that we have in self-management to make champions of children for their own disease state as well as adults. We want to make that autonomy. We want to get that autonomy to drive personal accountability. And that's where shared decision-making comes in and gives them the opportunity to contribute to decisions in their care. So this is an article that I thought was really interesting, and the pictorial display, in order to organize it better to understand, I thought this was an easier way to view it, but the information made it really interesting to sort of see what are some age-related challenges that have been identified in a large group of patients that have been studied. So when it's less than 5 years, we look at the self-report systems, right? Those we can't depend on necessarily the child to report, but their caregiver. If the caregiver has health literacy issues, we may not be able to rely on their account, even though that's the only account we have. So having the tools that help us, that are more validated, having the tools that are simplified to help increase accountability and validity of what's being reported is a challenge for that group. Looking at the ability physically to use certain inhalers. So knowing spacers need to be on board. How often should a spacer be refilled in a pharmacy? Does the family know how to clean and care for the spacer? How are they storing it in a backpack or a purse? Or how does the child understand how to use it? Does somebody around the child know how to use it in order to coach them? And so again, those are issues. The physiology and structural development, we've heard a little bit about that this morning, literally being a contributor to things that we need to do different. As patients are aging, understanding that there may be some differences in how we coach them through. Maybe certain devices are not going to be able to be used. And so again, looking at then what is approved for certain age groups limits some of the therapeutic options. As we see safety data coming in for more of our products, we see that there's a change in the accessibility, especially with the age. From 5 to 11, we look at more validated self-reporting, right? We're picking up a little bit of that. We know that the child's brain, right? They don't fully develop the brain until the age of 25. So there's still some things that we have to be aware of with adolescents and young adults. We look at, again, physiology and structural development. When are the lungs fully developed? How are we breaking down what we're doing by age group? What are the interventions? What are the guidelines say? What are the opportunities that we have for different medications and treatments? From 12 to 7, that idea of compliance, which really needs to be more about adherence. When we think about our preteens and our teens, there has to be buy-in. They are a challenging group because we have, from their own developmental state, kind of that idea that they want to fit in, they want to be the same. So having something that makes you different is a challenge to overcome. The draws of other things that for risk factors, vaping, smoking, those are, again, challenges in understanding those risk factors and what that does for the outcome of their disease is very important. What I thought was really interesting was that they've grouped kind of 18 to 60, but it's really 18 to about 30, and then from 30 to 60. And both of them have those pieces identified that they're transitioning from pediatric to adult care. That's a huge component. When they leave their pediatrician or they go away to college, they don't have somebody managing their health for them. And if you think about a young adult, a teen who's graduated and moving into school, if their health issue interferes with their scholastic performance, they have one episode, maybe 2 episodes in the fall, their GPA will never recover. It never recovers. So having the conversation with somebody who's going away to school of the importance of adherence to their medications to prevent any exacerbations in their disease state is important. If they do have an event and they have to miss school, to make sure that they have advocacy in order to protect their grades, because then that has become a barrier for them that they carry throughout the course of their educational attainment. And that was an initiative that we tried to do at USF, was really make sure that we've got that conversation happening. And what the health system has designed is that every new freshman would be assigned a primary care provider at campus who at one point in that first semester they had to make contact with, so that there could be some level of establishment there. And it was pediatricians. And so again, getting them to understand how to use their insurance card. What does it mean to get a refill? Just because they walk in doesn't mean that they're going to be able to get the medication. They have to have those doctor's appointments. And so that's a huge component of self-management, is really educating them in that transition. From 30 to 60, 24 even, getting patients to understand, do they want insurance? What level of insurance care do they need? What is their prescription plan? What are the limits of that plan? Because a lot of young adults are trying to opt out of services so they have a larger paycheck, not recognizing that that's something that's going to create a problem for them in the long run. Changes in lifestyle. That's a huge piece of managing from 18 to 60. And I would say continues on beyond that, because you're looking at people who are moving into senior communities, people that are maybe losing access to their families if they're at an assisted living or a long-term facility. And so again, I think that accommodation to lifestyle and changes in lifestyle is a huge component that extends. Then we're back to 60 and over, and we're again to the physical ability to use certain devices. And so we kind of have this cyclical component of managing different age-related challenges. And then we have our global challenges that, regardless of age, are an issue. Making sure that we have pulmonary function testing, that we've got baselines on asthma function and lung function from being able to compare between providers, getting those records transferred to the next set of providers, to the next set of providers so that we don't have gaps in care. And we talked about earlier how, at a certain age, they're just using the diagnosis of COPD when maybe that's not accurately reflecting and it's asthma. And then that's not going to be managed well, which leads to additional morbidity and mortality. So we want to make sure that we're doing the things that we can, increasing the education, increasing the awareness of triggers, empowering them through relationship building so that they are able to be better at managing and having those conversations. We've spent time talking about the social determinants of health, and we know significant impact falls in asthma, especially with environment and access to care. We have invested in greater resources in probably the last 15 to 20 years for asthma management in the recognition and integrating that into the guidelines of education and trigger awareness. Indoor air quality, outdoor air quality, making sure that there's allergy testing, being aware of environmental contributors that are going to affect the outcomes of patients with asthma. Those are huge pieces. And literally at the core of so many of our patients' issues is that health literacy component. One of the things that I thought was amazing is one of the pharmacies that I had worked in is one of the patients, and I can't remember and wouldn't say, but can't remember who was their care provider at the time. But this was a person that I knew was illiterate. And he shared that. But he knew more about his disease than half of the people that I had worked with clinically. Because whoever his provider was in their care team made sure, because he couldn't read, he knew it. And he knew it well so that he could navigate without being able to read a whole world that affected him as a patient with asthma. Which inhalers, how to use them, how to check to see if they still had refills, how to navigate, establishing a consistent pharmacy so that there was a relationship again, and if there were concerns, they could reach out over to the care provider. That was amazing to me. And that is the goal that we need, is that above and beside anything else, that they know so much about their disease and how to manage it, what their triggers are, when they've lost control, what they need to do that they can regulate through their asthma action plan, and when they need to go for help, so that they're returning to their care providers before they're depending on the health system in urgent care, emergency department, and then ending up hospitalized. Those are things that he was able to overcome. Even as a person who was illiterate, his health literacy was astonishing. Making sure that we have those opportunities, making sure that we have those relationships is really a huge component. The relationship piece, right? Imagine a relationship that you're in. If there was no connectedness, if there was no conversation, that wouldn't be a healthy relationship. And what we have as engagement with our patients is just that. It's that relationship. And it's something that as we cultivate it, we see more outcomes with our patients in the direction that we want, because we're seeing those belief systems change. And the confidence that comes when the belief and the behaviors come together is really kind of that place that we want all of our patients to be. We know all of the components of social determinants. We've talked about the health literacy and looking at the guidelines. Even the GINA guidelines talk about health literacy and the importance of addressing health literacy in the course of the treatment of the patient. And because we need to understand how health literacy affects our patients, we've been able to study and see, based on data, where these core issues are. We know that low literacy correlates to poor knowledge of asthma as a disease process. It correlates to misuse of the medications unintentionally, and then optimal outcomes, whether it's from the inhaler technique, knowing when to take which medication, not confusing the rescue or controller with the rescue and the control medications, making sure that they understand which one is for which time period. And we know that low parental health literacy increases the cost and risk of care of children with asthma. Making sure we have the personalized plans. Dr. Ramirez was talking about, and Dr. Perpich, both, we have the opportunity for more personalized care. We have opportunity for personalized medicine, but we still have to make sure that that includes the relational component between the providers, the team, and the patient, or the patient's caregiver if they're a pediatric patient. We want to make sure that our patients are optimized. We want to look at how well they understand control, loss of control, symptoms, triggers, different seasons, different activities, because as they're able to navigate that, we're able to see those improved outcomes. With adolescents, one of there's several studies, a lot of literature on it, but several studies that talk about that age being a very unique component. They need to have that identity, that autonomy, and working with that group can be a challenge. It's very unique. Who works or has an adolescent? Who works with or has an adolescent? How well do they listen? If they even put their phone down, right? How well do they do the things that you've asked them to do when you've asked them to do it? And you know their hearts. They're good, right? We love them. Sometimes we want to hug them around the neck, but we can't. But this is the same thing with care. They sometimes are dismissive, some are great, rule governed, and they want to do what they have to do. But without the understanding, we don't know what impact we can have. And so this is a unique opportunity to make sure that they have the knowledge, they have self-efficacy involved, that we've got, plenty of opportunities then to help them decide that they're making choices. It's their choice to do certain things instead of expecting them just to do something because they've been told. We've gone and spent a lot of time on risk factors, so I won't belabor this, but we do know those risk factors come into place significantly. The inclusion of the patient and the family unit is also something that we want to make sure is on board, and being able to respect the difference between an adolescent or a young adult in disagreement with the parent of what they do or don't want to do, which medications they want access to. When a parent has reservations and doesn't want to start a medication that we know is the best next option for the patient, and how to work with that resistance is an important piece. Looking at the opportunities to empower caregivers, but also empower the teens is another huge component, and getting those social supports in place. We've already talked a little bit about the health beliefs, behaviors, and outcomes, but really kind of looking at, again, sociocultural influences in the levels of care. So if we think about each group, the unique challenges that they present with, things globally that we have to continue to reassess as they're changing through these different groups, that's what's going to lead us to the most successful self-management for each of our patients and their caregivers until the patient is beyond the caregiver's domain. Engaging and empowering patients is huge. Relationships are the drivers of that, and making sure that health literacy is something that we keep on the forefront and we continue to change, because a person's belief can change over time, and a person's belief can be influenced over time. And that shift it's not always apparent. So they think they're doing the right thing. They think they're following what they've been told, but somewhere along the line, it's drifted just a little bit off from where so that retouching and having that re-explanation. So just wanted to say thank you guys for being part of that better tomorrow for our patients, and really understanding that there's so much work to be done, but there's so many resources that come together to do that. And imagine what it would feel like to be a patient with asthma and be a part of the team that you would want. That's how we change things for our patients with their outcomes. And we know that we can give a better tomorrow. We know that we can change a person's outcomes, whether they have asthma or not. So thank you guys for your time. Thank you guys for your attention. We know everybody's got to get on the road, and I think, is Zan going to close? Yeah, if anyone has any questions, great. Otherwise, we can move on to Zan.
Very new to asthma. We're looking at emerging adults.
Mhm.
You mentioned the ages of 18 to 30. That's the age range we're interested in. The PI that I work with, she came from Detroit, where a lot of issues, respiratory issues,
Right.
of course. I can't get the data I need to look at what the situation is like for this specific population, as you have on the slide, 18 to 60.
Mhm.
I would like to be
To-
able
to-
for us
to-
to tease that.
Right, to tease that out to 18
Where
to
would
30.
we look?
Have you guys reached out to the department, the Florida Department of Health?
We found
They,
oh,
right here next door, across the aisle, they exist.
great.
But they have, not only do they have data, I can make a shameless plug for the Department of Health with data, is not only do they have data, but they want you to use it. They want you to use it. So they'll be very happy to give it to you.
Any other questions? Can I ask a question, Dr. Garcia?
Yes.
Being a certified community health worker, we provide health literacy classes that we make in-house, or the curriculum we make in-house. But there's also the Self-Management Resource Center.
Yes.
That was originally developed by Stanford. It's evidence-based. I'm just wondering, and hopefully this would be the room to know, is there an evidence-based curriculum already available specifically for asthma?
Not for the best practices for self-management. There's loosely a lot of articles that talk about these are the components that you should have. There's a few management from like an ambulatory care setting, like what are some things that are going to improve outcomes for patients, which is geared towards, though, the clinic to increase billing, to increase reimbursement, but not so much for the patient. But that would be an amazing project. Well, they have for the certified asthma educator, but for community health workers, right. Yeah. Yeah. Repeat the question. So the question was, what about using certified asthma educator curriculum? And there is a bit of a difference in that, because the certified asthma educator curriculum is for the asthma provider. It's still not geared towards specific training of self-management, but there are amazing components to that, as well as some of the literature. But yeah, that'd be a pretty amazing development.
And
Perfect
there is
master's project. If you need a mentor, let me
the
know.
comment in the room was that there is a master student that was referred, and that would be a very interesting project to undertake. There is a virtual question. Are there literacy tools? Sorry, it just disappeared. Are there literacy tools available online? Zan did encourage them to email the Florida Asthma Coalition. Thank you, Zan. And to provide some more specifics so that they can be connected. But Dr. Garcia, I didn't know if you wanted to talk a little bit briefly on potential literacy tools you may be aware of.
There's actually a significant amount of literacy tools. The American Lung Association has them. The Department of Health has them. Several different asthma coalitions and organizations do have some that talk about literacy and the importance of it. But again, the specific components of increasing literacy is deficient. The training module to teach self-management is deficient. So again, those are two great areas for contributions to create. But the health literacy is specific to asthma, at least from organizations nationally. There's several that they can tap into, but sending the information on to FAC is a great way for us to connect them.
And there is there's plenty of kudos to all of the speakers, but someone wrote, as they say, I can listen to Dr. Garcia present all day. What a way to wrap up the seminar. And I cannot agree more. Were there any other questions in the room or potentially online? Not. Thank you, Dr. Garcia.